Good morning, everyone. Of course, first of all, Katarina, thank you for this kind introduction and for your invitation. So today I will show you some information about menopause and migraine. What we know about migraine is that it's the most prevalent in women during their reproductive years. And migraine is ranked as the second highest cause of disability worldwide and the first among women aged 15 to 49. But today we will not speak about this population, but we will speak about those beautiful, happy women yeah, during menopausal transition. So, what we know about menopause? Menopause, natural menopause, is defined as the absence of menses for longer than 1 year, so 12 months. Menopause may occur suddenly or be more gradual phenomenon. And in Europe, menopause appears around the age of 51. As the first speaker, I will also show you some definitions which we will use during the session. So, as you can see, we have different stages. At first, we have premenopause. So, overall, here, last menstrual period within 2 months, no variation of cycle length exceeding 7 days, less than 1 missed menstrual period in the past 12 months. And here still we have regular cyclic fluctuation in serum estrogen and progesterone levels during menstrual cycles. Then we have perimenopause. We have early perimenopause and late menopause. So the first one definition is last menstrual period was within past 2 months, variation in length of menstrual cycle exceeding 7 days, and missed maximum 1 menstrual period in the last 12 months. And when we compare the hormonal levels to premenopause, we have serum estrogen levels higher and progesterone levels lower in compared to menopause. In late perimenopause, both of the following are needed. So last period was between 2 and 12 months ago and missed at least 2 periods in past 12 months. During menstrual cycles, serum estrogen and progesterone levels are lower relative to premenopause, with amenorrhea very low and minimally fluctuating serum estrogen and progesterone levels. And now when we think about menopause, we have early menopause, so no menstrual period in the last 1 to 5 years, and late menopause, so no menstrual period for more than 5 years. And for menopause, we have low and minimally fluctuating serum estrogen and progesterone levels. At this figure, we can see how the level of estradiol is decreasing and the level of follicle-stimulating hormone is increasing during this transition. So, what is the belief? The belief is that migraine will stop entirely when women reach menopause. So I should ask you, is it true or false? But we don't have time to do it. So I will show you the newest data here about it. So this is a study from Norway from 2025. And together, authors included more than 20,000 women, and almost 24% of them reported ever having experienced migraine. So at the left side, we have a figure which shows age-specific prevalence of migraine. And of course, here we have a peak in late 30s and early 50s. But what authors found out is that mean age at menopause was 50.1 plus minus 4.3 years for all women, with no difference noted between migraine without aura and migraine with aura. Mean age of migraine cessation was almost 50 years, also with no substantial difference between migraine subtypes. Nevertheless, a little bit more than 9% of women reported the onset of migraine after age 50. And also continuation of migraine attack after menopause was reported by a little bit more than 46% of participants, also with no significant difference between women without aura and with aura. And despite those findings, 80.7% of women reported migraine cessation before 60 years of age. Here you can see two figures, so at the left side, age at first migraine attack, and on the right side, age at last migraine attack by migraine type. And orange dotted line here, represent mean age at menopause. And we can see that the prevalence of migraine without aura was a little bit more higher than for migraine with aura. And this figure shows a kernel density plot which displays individual years of migraine before and after menopause. And here, the point 0 represent menopause, yeah? And at the x-axis, we have represent years of migraine. And when we see negative values, yeah, they represent year before menopause. And here the density is, I would say, relatively low, but this density increases rapidly when we approach menopause. Yeah, and then after menopause, this density decrease. So that suggests that migraine become less frequent as time progresses post-menopause. This is the next study when authors try to check the association between perimenopause and menopause with high-frequency headache in women with migraine. So we can see we have 3 groups: premenopause, perimenopause, and menopause. And that's this table. So authors compared perimenopause and menopause with premenopause. And what we can see is that they found out significant differences, so higher numbers for current use of migraine preventives in perimenopause and menopause. Also, medication overuse was more often in those stages. Authors find out also significant differences for age, depression, and allodynia. And in this study, authors also created a model of being in the high-frequency group, yeah, and they compared in this table, yeah, they compared perimenopause and menopause to premenopause. So in the first model, after adjust for sociodemographics, authors obtained higher odds ratios in perimenopause and menopause of being the high-frequency headache group. But after adjust for all covariates, such as BMI or current use of migraine preventives, these numbers were only significant for perimenopause time. Also, depression and medication overuse significantly increased the probability of high-frequency headache. In this model, authors compared early perimenopause and late perimenopause to premenopause time. Yeah, and again for this first model, after adjust for sociodemographics, both, so for early and late perimenopause, they obtained higher numbers of odds ratios. And after adjust for the second model, yeah, those data were significant only for late perimenopause time. And there is also the third set of models. We cannot see it because they didn't show it. But for this model, they compared the early and late menopause to premenopause. And for the first model, odds ratios for early and late menopause were increased, so that they were associated with an increased risk of high-frequency headache, but both lost significant in the second model. This is a study from Italy from this year, and in this study, authors checked headache diagnosis in the elderly. So you can see that the total numbers of included patients were more than 2,000, and from this group, 75.39% were females. Yeah, and they divided the group into 4 subgroups: so elderly, middle-aged, adult, and young. And you can see that for elderly, such diagnosis as neuralgia, secondary headache, other primary headache, as well as probable headache were much more often. Also, episodic tension type headache and chronic tension type headache were more often. When it compared to chronic migraine, authors find out that chronic migraine prevailed in the elderly, and they found out also that in elderly, migraine without aura was a little bit less likely than in other groups. And now we will move to the treatment. So this is a study from UK from last year, and here authors checked the utilization of oral contraceptives and hormone therapy for menopause among female individuals with migraine with aura. And we can see that, nearly half of post-reproductive age individuals use hormone therapy for menopause. And of this group, here, we can see how changed the route of administration of this prescribed hormonal therapy. And the most often was transdermal, followed by vaginal and then oral. Nevertheless, we can see that administration of oral hormone therapy decreased with time. This is quite, I will say, old study from 2007. And in this study, authors checked hormone replacement therapy and headache prevalence in post-menopausal women. And in general, they found out that for headaches, the odds ratios were significantly increased for all hormone replacement therapy, when compared to never users of HRT. For migraine, the increase was significant only for present systemic use here, and for non-migrainous headache, also for previous use. Then they conducted an analysis among HRT current users. And you can see that for headache, in general, odds ratios were significantly increased for all all categories of hormone therapy, but also for all way of administration. When we see migraine headache, this increase was significant only for use of HRT and ERT, so estrogen replacement therapy. And for the administration form, authors obtained higher odds ratios for all the forms, but they were much higher for the systemic form, so systemic use. And authors also done a separate analysis amongst women older than 65 years of age. And this analysis revealed similar trends of increased odds ratios among all HRT users group, and the trends being most marked for systemic use in migraines. And this is the last study, also from Italy. That was a prospective single-center study. And authors included two groups of female, menopausal female and female in fertile age. And we can see that in the menopausal group, 25% of female had surgical menopause. And in the study, patients were regularly treated with an anti-CGRP monoclonal antibody monthly for 1 year. In this analysis, authors tried to find significant differences for such variants as the average number of headache days per month in the last 3 months, average number of painkillers taken per month in the previous 3 months, the average number of days per month in which the patient took at least one medication, the headache days per month, as well as HEAT-6 score and MIDAS score. And when authors compared women in menopause and women in childbearing age, only one significant higher numbers they found for the AC, which was significantly higher amongst women in menopause and the 3rd, 6th, and 9th month. Then authors compared female in psychological menopause with women with surgical one, and they found out no significant differences, and no significant differences for menopausal female treated with erenumab and galcanezumab. When we see the excellent responders rate, they were higher in female with childbearing potential, and there was no significant predictor of an excellent response among postmenopausal women apart from a lower AC and the baseline. Authors also checked the proportion of adverse events, and they noted no significant differences between women in menopause and in childbearing potential, and the most common adverse event was constipation. So, in the summary, menstrual cessation does not necessarily equate to migraine cessation, and it seems that there is a gradual decrease of the prevalence of migraine with increasing time since the last menstrual period. Even through menopause has been confirmed, migraine persists in a subset of female, it seems like 1 in 5. We cannot forget that due to the aging population, we will see higher prevalence of migraine in the future, yeah? And it will be a serious problem in health. The interplay between cerebral changes and hormonal fluctuation during the menopausal transition may have a decisive influence on the patterns and course of migraine. There is a higher risk of high-frequency headache during the especially late perimenopause, as well as in menopause when this patient has, for example, depression and medication overuse. But with this treatment, when we think about analgesics in menopausal women, we cannot forget that different disorders will be found in this time, in these females. Yeah? So, for example, osteoarthritis. So perhaps they are also taking this medication due to other disorders. An increased prevalence of headaches, both migraine and non-migraine, was found in postmenopausal women using HRT, so systemic and topical, and all forms of administration. Nearly half of post-reproductive age individuals with migraine with aura use hormone therapy for menopause. Nevertheless, it seems that anti-CGRP monoclonal antibodies are effective in this group. And last thing I want to show you is about this headache diagnosis in the elderly. So they are much more often diagnosed with chronic migraine, with probable headaches, because this change, yeah, we will see other symptoms, for example, bilateral headaches. And the diagnosis of secondary headache are much often in the elderly. So thank you for your attention.